Hey, folks, we'll get started. We're good, Chief? Sweet. We're live at the with Albertville Fire and Rescue at the Rec Center. So if you're in the area, come out. We're out here till about 2 o'clock today. We're going to do lectures, myself and Dr. Beach, and then we'll have lunch and do skill lab. Survival Flight 16 is here with us as well. So thanks for coming in. That's right. Yeah. Yeah. Sweet. So we'll get started. So we got. Hey, hey. Hey, Chief, is our clicker not working today? All right. Sweet. Thank you, sir. No worries. No worries. So this in 2014 to bring physicians at Con Ed back into the realm of EMS. When I was doing EMS years ago, there seemed to be more physicians involved. So currently at UAB, we get 12 new residents a year. We got 36 ER residents and probably a dozen fellows in different subspecialties. But the goal is to bring these docs out in front of you guys, let them start doing some time with y'all to get more excitement about EMS and the physician side. So we have an accredited EMS fellowship. Those are docs that have completed their ER residency, 3 years of training, and they spend a year with me. We can take 2 of those a year as well. They get out, they ride with Birmingham Fire and Rescue. They actually have done some flights with Survival Flight 16. We have a contract with you guys. So you'll see them out there and about in the greater Birmingham area. Some of our fellows have already graduated. We got one up in the Huntsville area. We got one in Birmingham. We got a graduate that will be in the Mobile area as well. Or he's our ER resident. He did his training in EMS in Texas, but he was from UAB. Disclosures, we're not going to say anything. I will give you some opinions, and that joke about opinion stands true. If I say something that sounds inappropriate or weird, you don't want to do it, more power to you. Talk to your medical director and see what they think about these things as well. So. For your Con Ed, be a QR code on the chat box for those online. For you guys, we'll post it on here at the break as well. You can always email us at alabamaemschallenge@gmail.com. We have Con Ed for physicians, for nurses, and for EMS providers. This is all free. You can find this stuff on YouTube as well if you want it. If it's beneficial, use it. If it's not, you won't offend me, but you got to do some kind of training, some kind of Con Ed to stay up. Healthcare changes rapidly. The things that are in the textbooks right now that were published this year are 2 years old and probably 5 years older than that when you think about some of the things we're doing clinically. So you got to keep up. We'll be in at Brim's August 14th. There'll be a special guest there. We'll have some talk about our new snakebite clinic we have in Birmingham. The 21st, I haven't told Chief yet this either, but we're going to do a makeup date. We had to miss the Talladega event in January due to the ice storm. So we'll be at Talladega at the track. Great chance to come out, see behind the scenes what we do there. The 28th, we're in Prattville. We're back in Birmingham in September. And then October is Irondale, and then we'll be at the Mobile Convention Center. And then November, we'll be at the State EMS Conference. The other cool thing we got going on is the 29th and 30th of August. There's a free cadaver lab in Birmingham. I know it's a drive for some folks, but we have access to donors there where you can do chest decompression. You can do IOs. If you come to the first day, we'll be able to do some chest tubes and surgical airways as well for those of y'all that can do that. But that should be a Thursday afternoon and a Friday. We'll have access to cadavers, and that's all free. It'll be posted on our Facebook and the page, and it'll be on the Alabama Fire College website, and that'll be posted probably the first week of August. You do have to sign up for the cadaver lab. It's still free, but I can only fit so many people at a time in that room as we do that. So airway management, I hit this hot and heavy every time because it's super important. You guys in EMS, the EMT to the advanced, to the medic, to the flight guys, y'all should be the masters of airway management. People die without an airway, okay? All right, so from simple maneuvers, OPAs, I'm a big nasal trumpet fan. We're going to use that today in some of the labs that we do. OPAs are great. They were the standard of care for a lot of basic airway devices in the past. I think moving away from those and using biads like Kings or iGels is probably better because the risk to benefit's the same, but they give you a better way to ventilate. But nasal trumpets are good as well. What do y'all carry for a blind insertion device down here? Y'all got Kings or Kings and iGels? Cool, yeah. So I'm more of an iGel fan. I think they're almost idiot proof, so I can use them. You know what I'm saying? But Kings are fine if that's what you got. I guess the issue with Kings is you can't get the PD ones anymore. Yeah, so. And then obviously I think for medics, definitive airway control for ventilation is going to be an ET tube. So are y'all got video scopes in this area? Yeah. So you can get video scopes now for under $2,000. If you can't afford that, reach out to me and we'll find some help for you guys. It's revolutionized airway management. It takes that patient that's 4'8", 350 pounds from being a difficult airway to, hey, not a problem because I got a video scope. It's like cheating, right? And it's okay to cheat if you want to win. All the way up to the scalpel and Imodium for the flight crews. And why do we talk about Imodium in airway management? That's an antidiarrheal. Get it? Because it's scary. All right. I thought it was funny. All right. But you guys should be the experts. And that, again, that's a present for Chief Ward. When he figures out what it means, I'll stop showing it. Friendly reminders. I usually do this for the region, but for everyone, remember 12 leads. If you get one, I would document in the narrative what you get. I get it. You have a printout of it. You have it saves to your record. But you need to be able to put on there 12 lead taken at 9:15 and be simple. Sinus rhythm rate of 60, STEMI or no STEMI. That's really why we're doing these for the most part, right? And I say that for two reasons. One, when your data goes to the state, a lot of times those strips don't get attached and the hospitals don't get that data. And we want them to have our data, so they want us to be involved with them, so we get more data sharing. We're probably 5, 8 years away from hospitals sharing data with us universally, is my hope. And that's going to be really good for us as far as knowing past medical history, for billers, and just for continuity of care. The other thing is, if we get some legislations changed and we're able to bill for care on scene without transport, right? This is a billable item that we can do. Okay, so for patient care and for billing reasons, I'd recommend when you get a 12 lead on someone in the narrative, just put the time, a rate, is it STEMI or not a STEMI? Nothing fancy there. Capnography, any advanced airway's got to have capnography. You cannot defend that in court if you don't have it, and that means a King, an iGel, or an ET tube. My advice, when you place one of those, you document that you see a waveform, and you put the number down. When you're done with the call, whether you're calling it in the field, or you get to a hospital, or you transfer care to another provider, your last line should state, hey, ET tube still in place, capnography at 45 with a positive waveform. That way, if someone's reviewing that chart and they read that, they know that airway is fine. They can stop right there. They don't have to pull strips or anything. It's going to keep you out of trouble. And more importantly, it prevents you from having a misplaced tube, which unfortunately still happens today. And it shouldn't with videoscopes and capnography. Okay. Epidosing, cardiac arrest, first dose epi should be as quick as you can. The second dose, I'm saying push out to 5 minutes. Talk to your med director, see what they think. Some places are doing epi drips. Some are breaking out to 5 minutes. Some are even going further. We know first dose is important. Second dose, not so sure because more risk there. Narcan and cardiac arrest. There's no indication for nasal Narcan and cardiac arrest. If you have no pulse, no blood's going to your nose, they don't get nasal Narcan. Narcan should be given to people who are altered and not breathing or breathing just 1 or 2 times a minute. And you give nasal Narcan after you've done passive O2 and you ventilate them for a few minutes. And then you give the Narcan and they wake up nice and happy and they hug you and thank you for your service, right? Right? Yeah, they don't, but they wake up a little bit happier, right? The other thing is, if it wasn't an opioid, if they have a head bleed or something else causing them to be altered and not breathing, you've already fixed the problem with your passive O2 and ventilation. My advice, 1 dose of nasal, if that doesn't work, you just keep bagging them. Now, if the patient's 3 foot tall, 500 pounds, you know you can't ventilate them and they're not breathing, I'm slamming Narcan in quickly, but that's a different reason because I know I can't ventilate them. Does that make sense? Cool. Sweet. Oh, Narcan humor, semi-inappropriate. And then I talk about capnography every time. The translation, pornography, that was funny. Sorry. All right. Transport. I know that for our state, the guidelines are being rewritten about death in the field. Just a couple of tips, advice, places where I'm the medical director, this is what we're going with. One, we don't say death in the field. That is a legal term. I know the protocol talks about that, but my advice is that when you document what you're doing, you write, I have orders received to stop resuscitation, to cease resuscitation, to not start it, to not do CPR, whatever you want to phrase it. Don't use the phrase death in field, time of death. Okay. And the reason we say that is because legally only a doc or the coroner can do that. And it just kind of keeps you out of trouble. What you're doing is you're getting orders to not resuscitate somebody. Duh, we know they're dead, but just kind of stay away from that terminology. Remember, if they were ever alive at any point in contact with you, state rules say you have to transport them. If they were talking to you, if they had a pulse, you work them where you find them, but you also know that at some point, be safe. All right, that's right. They were alive at any point with you guys, you got to transport. You work them where you find them, okay? But you realize at some point you're going to move toward the hospital. All right, be safe getting there. No lights and sirens. Keep working them, but you got to transport. My advice: if you have citizens that do chest compressions on someone, okay, and they're not in rigor, and you get there and you're working them, you're going to transport them as well. Seen on them, okay? Persistent VFib, VTAC, can't really stop resuscitating those people. Talk to your medical director. How do you define that? I define it at some places as 2 shocks. So if someone gets there, they get 1 shock by the engine crew, the next shock by the medic. They've had 2 shocks. They got a dose of amio. We're going to call that persistent VFib, and we're going to take them at some point toward the hospital. Okay. If they're an active VFib, VTAC without a pulse, you should not stop that resuscitation. All right. And then the other thing that I use is capnography. So if we're getting to the point where we're not going to work somebody, we should have an advanced airway in place, either an eye gel or an ET tube. If their waveform capnography is greater than 20, that makes me think, that's almost close to physiologic. Maybe they could be alive or have a chance. So we keep working those. Okay. That's my thought. Thank you for almost smiling. Good, good. Sweet. Every agency has to have their QI policy plan in place when they reapply this year to the state. QI should not be aggressive. They should not be inflammatory. It should be a learning process. It protects the patients. It also protects you guys. If y'all need help with a QI plan, we got one at Brems. We're happy to share with you guys. You can use all, part, or none of it. No obligation, just if you need help. But you got to have one for July 1 for your new license in the state of Alabama. I'm not sure what that cartoon was about. So let's talk about 12 leads. So I know that in paramedic school and for the nurses out there and the docs, we learn about vectors and things of that nature. And that's great. I learned it years ago, but that kind of blows my mind sometimes, especially when I've been up for like 3 days straight and it's 2 o'clock in the morning. So I kind of have a memorization the way I look at EKGs and the way I approach these. So when I'm looking at a 12 lead, I think it's a screening tool for badness. I'm looking for STEMIs, looking for things that kill people. And I'm determined, do I need to manage this patient right now, or do I have time to back away and think a little bit more? So I look at the ventricular rate. Is it too fast? Is it too slow? Or is it okay? I use rates between 50 and 140 is my normal rates. So greater than 140, 150 is too fast. American Heart has it pretty good. I think you'd say, is it wide or narrow complex? Is it regular or irregular? And that algorithm I really like. Too slow, I think of 3 things that make you too slow. Rates less than 50. Drugs, electrolytes, or really one electrolyte. What electrolyte is that? Anybody know? Anybody care? Comes in a banana. There, I like that. Yeah. Who eats bananas? One person. Very good. This is Alabama. We're unhealthy, right? I eat Twinkies is what I eat. Yeah. Sweet. So potassium. And the third thing is ischemia. Anything else that makes your bradycardic, you can pick up by doing an exam. For example, you pick up a dude shot in the belly. He's calling you names. His heart rate is 140. En route to the hospital, he starts bradying down 140, 110, 90, 50. What's going on with him? What? I hear mumbles. He's dying, right? Hypovolemia. He's in shock. He's bleeding out, right? Yeah, I don't need the EKG to tell me what's going on with him, right? What about the 6-month-old that you pull out of the pool that's blue, has a heart rate of 40? What's going on with them? It's respiratory, right? So if you can't pick it up in your primary exam, most of the time it's either drugs, beta blockers, calcium channel blockers, the electrolyte potassium, or it's a bad heart event. And then the more scary rhythms sometimes are the ones that are okay, rates between 50 and 140. You got to determine, is that a STEMI? Is that not a STEMI? If you get deep into EKGs, you can find infection, you can find certain drug overdoses. You look at your intervals for things, and you can also use AVR to find you some kind of pearls of information. So too fast, too slow, and okay-ish. And this is the same way I teach EKGs, whether you're an advanced EMT that can now look at 3 leads by state, you're a medic, you're a flight nurse, or if I'm talking to docs. This is the way I look at EKGs, okay? This is a screening tool. Yes, you can get really deep with this if you're a cardiologist, but for us, it doesn't matter, right? We're screening out madness that hurts people. Know how to calculate a rate. Don't just trust the monitor. I use the box method. If you have a different way, more power to you. I can't use those calipers. I can't see the ends of them anymore, right? But I can make this and look at the boxes. So first box is 300, 150, 100, 75. At that point, I'm thinking about going fishing or having dinner. When my mind comes back to normality, I look up, it's way too slow. Box method. Next thing is I'm looking at intervals. I'm looking at my PR interval, my QRS, and my QT. If I don't know what a Y complex QRS is, I can't determine is it a Y complex or narrow complex tachycardia. PR intervals. What's important about the PR interval? What does a long PR interval tell you? What type of heart block? First 3. What do we do for those? Nothing. Yeah, nothing. Yeah, a lot of good information there. What'd you say? Oh, okay, okay. No habla, right? Yeah. Yeah. I also think if I got a long PR interval and a Y complex QRS, I started thinking hyperkalemia, right? Textbooks talk about peak T waves. Who cares? What gets you is when that PR interval gets real wide and that QRS complex get real wide, right? So intervals. And so with this one, I say, is this rate too fast, too slow, or okay? Okay, yeah, that's the easy one, isn't it? Yeah, yeah, rate's okay. Machine says it's 73, but don't trust the machines. Box method, I got 300, 150, 170, so 70-ish. It's okay. The next thing I'm gonna do is I'm gonna look for injury patterns. I'm looking for STEMIs, things that kill people, things we gotta address, right? So I'm gonna look laterally at 1, AVL, and 5 and 6. If I got ST elevation in any 2 of those leads, it is a STEMI. My job is done. Sir, you're having a heart attack. Ma'am, you're having a heart attack. I won't say it like that, you know what I mean? But, and I start my care for STEMIs, right? All right, if that looks good, the next place I'm gonna go is I'm gonna look inferiorly, 2, 3, and AVF. I'm looking for ST elevation. If I got 2 leads with ST elevation, it's a STEMI. If I see T-wave inversion, ST depression, it makes me think maybe there's ST elevation somewhere else. So I'm gonna look a little bit harder as I go through this. So those are my inferior leads. The next place I look is leads V1 through V4. These are your septal or anterior leads. Elevation there is concerning for a septal or anterior infarct. All right. If you have depression though in leads V2, 3, or 4 with T-wave inversion, ST depression, that is a posterior infarct, the backside of the heart. Some of the textbooks, some of the blogs talk about you can do a posterior EKG where you take their shirt off, put the leads on the back. I'm not doing that in the ER. This is enough information. If they made me concerned enough to get a 12 lead on them for acute coronary syndrome and they have this, I'm calling cardiology and I'm saying they're having a heart attack until the cardiologist says they aren't. Okay, so my advice is we aren't doing these fancy posterior 12 leads. This is enough information to screen them in to say, yep, you're sick enough, you make me uncomfortable, you go into a hospital to see the doc, hopefully a hospital that has a cardiologist that can cath you because I think you're having a posterior infarct. Next place I look is lead AVR. I know going through medic school, we talked about AVR is really not much we do with that. You can look at lead AVR. The QRS complex should be opposite the QRS complex in lead 1. That tells you that you put your leads on right. In reality, though, if you have ST elevation in lead AVR and depression in any other injury pattern, it's concerning for a left main disease. So if you think about AVR points this way, that's where the aorta is. So if you got elevation here, that means you got a clot probably in the right or left main coronary artery. And you tell that by saying if you're up in AVR, and I got T-wave inversion, ST depression in leads 1, AVL 5 and 6, I'm thinking that's lateral, that left coronary is jacked up, and that's a STEMI equivalent. They should probably see a cardiologist. If I'm up in AVR and I'm down in 2, 3 in AVF, I'm thinking that's the right side. Okay, and that's an early right coronary infarct or clot. Now, obviously, older folks who have heart disease and they're tachycardic or they're hypotensive from trauma or sepsis or dehydration, You see them get up in AVR and get that depression laterally or inferiorly just because they're underlying disease and you treat the underlying problem. But AVR is a pretty cool lead to look at. All right. The next place I go is lead 2, and I'm looking for my PR interval, my QRS interval, my QT interval, making sure those things are normal. If my QRS complex is normal, what I'm going to do is I'm going to go back one more time to make sure I'm not missing a STEMI, because some days I'm really tired. So I'm going to look 1 AVL, 5 and 6, 2, 3 and AVF, V1 through V4, and then AVR. And if that's fine, I'm done with that EKG. And my document is going to say, hey, sinus rhythm rate of 73, no STEMI at 9:30. Okay. If my QRS complex is wide in lead 2, I got to determine what kind of block I got. Is it a left or right bundle branch block? And we do that because you can really interpret those for STEMIs or no STEMIs too. So Y complex QRS in lead 2, I go to V1 and I'm looking. Does it point up or point down? If it points down, it's a left bundle branch block. All right. So keep this simple. There are a lot of rules out there for left bundle branch blocks, criteria. I can't remember that stuff at 9:30 in the morning, much less at 2 o'clock in the morning. So this is a quick, simple way to do it to screen your patient in or out for acute coronary syndrome. So if I was going to read this 12 lead, I say rate too fast, too slow, or okay. Looks okay. Yeah, it's not too fast, right? So we're 300, 150, 100-ish. Yeah, I'm good with that. I'm going to look injury patterns 1, AVL. I got T-wave inversion. It looks funky, but it's not a STEMI. 5 and 6, I got FC depression. Not a STEMI, but looks funky. 2, 3 and AVF, again, Y complex, but not crazy. V1 through V4, I would say it's Y complex, but elevated in V1 and V2, maybe V3, depending on who you ask. All right. So then I'm going to go over and look at AVR. I can't really see that there. I screwed that up with the arrow. And then I'm going to go over to lead 2. And I recognize my PR interval looks good. My QRS is wide. So I'll go over here to this V1. It's a left bundle. So I know with the left bundle, I could use something called Scarbosa's criteria. Have y'all heard of that? Yes, no, maybe. Some say yes, some say no. Yeah, cool. So Scarbosa is a way you can determine, is this left bundle scary or not scary? What Scarbosa says, well, we'll come back to that. Scarbosa says that in a left bundle branch block, if you have discordance, that means the QRS goes the opposite direction of the ST segment, you get one big box. So really 5 millimeters instead of 1, okay? It also says that ST elevation in the same direction as the QRS. So ST elevation in the same direction as your T wave is always bad. And if we had posterior changes in V2 and 3, that's always bad. So by Scarbosa, this one's okay. And I got a slide that talks about it so you don't have to cross your eyes at me. Cool. What causes a left bundle branch block? Anybody know? Anybody care? It can, yeah. So ischemia can cause this. So we used to say if you had a left bundle branch block and you're having a STEMI, we called you having a heart attack. We did all the things for you. We realized that a lot of folks have underlying heart disease and they'll get a left bundle and they don't need a heart cath or lytics or things of that nature. So chronic hypertension, the ventricle gets enlarged because of that, cardiomyopathy, heart disease, things of that nature, chronic can make a left bundle, okay? So anything that slows conduction to the left side of the heart makes that QRS complex get wide because it takes longer to get that electrical impulse through there. Cool. Just the other criteria, again, the easiest way to do it is QRS complex is wide, greater than 4 boxes, but greater than 3 boxes, and you got that downward deflection in V1. You can do that, but you know, for the most part, that's a little bit deeper than I try to go for the most. You know, my goal is to make sure everybody's got the basic STEMI interpretation and a left bundle or right bundle. But yeah, you can get really deep with left axis and right axis deviation. And if you're comfortable with that, fantastic. Use those rules. But for a screening process, trying to reach the masses, I think this is an easy way to get it done. So Scarbosa criteria, this is what I was talking about here. So ST elevation in the direction of the QRS complex is always a STEMI in a left bundle or right bundle or no bundle. T-wave inversion, ST depression in a left bundle for a posterior is always a STEMI equivalent. Sees a cardiologist. The only gimme you get really is discord. So QRS going down, T wave, ST elevation going up. You get a whole big box. So we're pretty good there. There's no way to get good at looking at 12 leads without looking at 12 leads. It's sort of like you can learn how to start an IV every 6 months, but if you don't start one for the next 6 months, you're no good at it. The only way to get good at 12 leads is look at a lot of them. So if you're not running and looking at 10, 12 EKGs a shift, find you something online to look at. Life in the Fast Lane is a good resource. Wave Maven is another good resource. There are a lot of YouTube channels. So find one that shows you an EKG and gives you a scenario and test yourself, okay? Otherwise, you will miss something one day and you will feel bad about it. Scarbosa, inappropriate humor from a movie several years ago. So this one, too fast, too slow, or okay? 300, 150, 170-ish. So I said the rate's okay. So I'm gonna start looking at injury patterns. I'm gonna look at leads 1, AVL, 5 and 6. I'm gonna come over and look at 2, 3, and AVF. I'm gonna look at V1 through V4. I look at AVR. AVR is opposite of 1, no big ST elevation there. I go over here to lead 2, and I say my P interval, my QRS. All right. And I got to decide, do I need to look over at V1? Is this a left bundle or a right bundle? Is this a STEMI or not a STEMI? So what's going on with this one? Left bundle or no bundle? Left bundle. STEMI or no STEMI? I hear mumblings in the back. Yeah, new onset is STEMI equivalent, but how do you know that? I would argue that most people don't know that. So, yeah. Yeah, if you got the good patient that pulls out his wallet and pulls out an EKG and hands you an old one, you're doing good. Yeah. Most of my, well, I can't say that. I was going to make a joke. Never mind. So STEMI or no STEMI? Who says STEMI? Raise your hand. Who's not going to vote? Raise your hand. There you go. That is America. Thank you, sir. I like that. So I would say if you look at 1, AVL, and 5 and 6, 1's got some ST depression, AVL's got some ST depression, 5 and 6 has ST elevation in the same direction of the QRS complex, right? 2, 3, and AVF, we got ST elevation there, but it's discord. QRS is going down, T wave going up, right? V1 through V4, a little bit of posterior changes in 2, but not down there. So by Scarbosa, right, this looks like 5 and 6. This is a STEMI. Big, bright, in your face, tell your mama it's a STEMI, right? What's the machine say? Unconfirmed. Most machines cut off interpretation if you have a left or a right bundle branch block and aren't going to tell you. Okay, so as a medic in the state of Alabama, where we have a STEMI system, okay, you're going to have to be able to recognize this is bad. Does anybody have issues with wall times anywhere? Right? So this guy sitting on the wall for 45, 50 minutes waiting for a bed, having a big STEMI, has a high risk of dying. First 4 hours of this event, people die from VTAC, VFib, or cardiogenic shock. You don't want to miss this. Machine's not going to pick it up. Unfortunately, or fortunately for the patient, if you know what you're doing, you can pick it up and save a life. So you got to be able to read that this is a STEMI. Wait, here's a cheat sheet, kind of gives you a guide, talks about where the areas of injury are. You can Google this, put it on your phone, get a cool tattoo on your forearm so you can look at it every time, whatever you want to do, right? Cool. The key thing is you got to be careful. You cannot trust the machines. What's wrong with this picture right here? Yeah, you can't do a 79 over 80, I don't think. Or maybe you can. I've been in school in a long time, right? That makes me uncomfortable, right? So don't trust the machines. For the older guys out there, remember that movie? Don't trust the machines. All right, don't trust the machines. And then for the newer generation, don't trust the machine. Okay, fair enough. All right, so this is a 37-year-old. You called for a lift assist. You get there and the dad says that she's just been laying on the couch for weeks and weeks. She's got a history of depression, bipolar. Her pet cat ran away, right? So not eating, not drinking, no shower. He just needs to move her from the couch to the bed. She's been on the couch for 3 weeks. So what do you think about that? What you want to do for this lady? 3 weeks straight, laying on that same couch, same outfit. Yeah, right. So there's some concerns with that, right? Yeah. So this is not the one that you just pick up and go put in the bed and say, thank you very much and walk away, right? Cool. So concerns for this lady, a lot of issues. Get a set of vitals. Always, I'm gonna get shot at for saying this. On all these calls that you show up, if the patient looks confused, altered, do an assessment. You don't have to get vitals. If they're looking at you, talking to you, things are great. If they're altered, they're confused, get a set of vitals. Gives you a lot of information. So this chick is just staring at the crew. She's breathing pretty fast. Blood pressure is 88 over something. Glucose is always a vital sign. EMTs, advanced medics can always do it. Gives you a lot of data. If it reads low, you know what the problem is. You can fix it. If it reads high, you know what the problem is. You can fix it. If it reads 354, what does that tell you? They live in Alabama, right? Yeah, sweet. Heart rate in the 40s, set 94%. So this right here should make you super uncomfortable. So what's the next test you want to get if you got a heart rate of 40? Yeah, throw in the 3 lead, look at that rhythm real quick. She's talking, not talking to us, but she's still alive, and then get a 12 lead, right? So you look 12 lead for screening for, I guess, nuggets of gold. And this is our 12 lead. What does that make you think of? Too fast, too slow, or okay? That makes me use profanity. It's like, ma'am, are you post arrest? You look like you're in PEA. Will you wake up and talk to me, right? Way too slow. So if I started counting the rates, I'm not going to do it because my ADD kicks in. I can't keep up, but way too slow. All right. So what 3 things can make you bradycardic you don't pick up in your primary exam? She's not bleeding out. She could be dehydrated though, right? Yeah. She's not hypoxic. She hasn't been shot. What 3 things can bug her? Drugs. Yeah. Yeah. Or ischemia. Right. 3 things, right? You know, I would argue in a 30-something-year-old, I'm probably not thinking ischemia. I've been burned with that before. So I'm thinking, has she taken some kind of beta blocker or a calcium channel blocker? Or is she hyperkalemic because she's so dehydrated? What's going on with her, right? So what are you going to do for this chick? I shouldn't say. Before you take her to the ER, yes. So you got a 12 lead, you got this. As a medic, yeah. Yeah, IV access and start some fluids on her, right? Cool. So on this 12 lead, I'm going to look for injury patterns. I'm going to look at 1, AVL, 5 and 6, 2, 3 in AVF, V1 through V4. I look at AVR. I go over here and look at lead 2. I only see 1 beat. I'm not really sure. Y'all see a P wave? Maybe in lead 3. I don't see it in 2, right? Cool. So, So the category for this is things that make you uncomfortable. The EKG should make you uncomfortable, right? Right. I had to do it politically correct so I don't get fired. And then Texas football should make you uncomfortable, though, right? So anybody want to guess what's going on with this lady with this rhythm? So this is hyperkalemia gone wild. Yeah, so peak T waves, but more importantly, that QRS is wide and that PR interval that you can kind of see better from this side, or I can, is super long. So this is that classical sine wave you talk about, and it's fairly common in the state of Alabama with our patient population of diabetes and hypertension and kidney disease, okay? But I got somebody that's been on the couch for 3 days, dehydrated. They can get muscle breakdown, get something called rhabdo, like athletes get or firemen get from getting too hot, right? Jacks up your kidneys, they get hyperkalemic. This is a near fatal rhythm if you don't recognize it is hyperkalemia. All right. And again, the way you recognize this is hyperkalemia is looking at a lot of regular EKGs and thinking, if this was ischemia, she should probably be in cardiogenic shock, almost dead. If it was a beta blocker or a calcium channel blocker overdose, that's potential, but this is classic hyperkalemia. So somebody already said we started IV fluids on her. We're going to rehydrate her. What else can we do for this lady? Calcium. So calcium gluconate or chloride, whatever you got is great. Stabilizes that cell membrane. Cool. We talked about too fast, too slow. Fluids, lots of fluids. People say, what if she has congestive heart failure? I say, it doesn't matter. She's hyperkalemic and volume down. She gets fluids. If she starts gurgling, what do? You set her up, right? So lots of fluids. The 3 S's of hyperkalemia is membrane stabilization, intracellular shift, and excretion. So we're going to start the fluids. Calcium chloride is great. It makes it so that she is not at risk or less risk going into VTAC or VFib. People with hyperkalemia that is that high, if you jostle a stretcher, if you drop them, if you go to intubate them, you get a vagal response, and they'll go into a Y-complex tachy. And you'll say, that's VTAC. So then you shock them, you give them lidocaine, you give them amio, and they die because they're hyperkalemic. It's not a real VTAC. Cool. What other drug can we give them? We give them fluids, we give them calcium. There's another drug we can give that the EMT can give this patient if the EMT were to see that. If you got a pretty aggressive EMT that knows their rhythms. Anybody know? Yeah. You can give albuterol. Albuterol is a great shifter. You give them 20 milligrams of albuterol. It's like 4 or 5 of the regular doses. You put it in a neb setup, you put it on their face, and you sit them up, you start your fluids. You'll see that EKG change, that QRS gets narrow while the albuterol is going. Now, once that albuterol neb treatment is done, the EKG will go back and they'll get hyperkalemic again. Okay? So that keeps going till they get to the hospital and we can shift it. For the flight guys, the advanced practice folks, you can do insulin and dextrose. Insulin opens up receptors in the cells that makes that potassium go back in. Okay? We give the glucose. If we give them insulin, they'll get hypoglycemic. And then there's some medicines we can give in the hospital as well. We can also do dialysis. However, in reality, even at the academic place that I work, getting someone to dialysis is probably several hours on a good day. So we treat hyperkalemia medically, and it can be treated medically in the field, in the ER pretty readily. There's some other medicines out there. There's one called K-exolate that causes people to have aggressive diarrhea, and it makes potassium shift to the gut. I would not recommend you guys giving that. I only give it in the ER if the nurse makes me mad, because that was kind of funny, but I'm joking. Sorry. K-exolate. There's some newer drugs out there. Lokelma works the same. But from a management standpoint, in reality, what we're going to be doing is we're going to be doing fluids to rehydrate this patient. She's going to get albuterol, calcium. If you're advanced practice flying or on a ground unit, she gets insulin and dextrose. And that's going to fix that EKG and limit the ability for them to go into cardiac arrest. So things to think about with that kind of patient is, one, the depression. Does she have capacity? If dad says she can't go to the hospital, she doesn't want to go to the hospital, what do you say? Yeah, she doesn't have the mental capacity to say no, right? It's an adult kid with their parent. Parent does not have legal custody of that patient. That lady's at high risk of death. She needs to go to the hospital. There could have been a drug overdose. The thought on that, though, if she'd been sitting there for 3 weeks, the odds of it being a true drug overdose are probably limited. She probably would have died from that. Dehydration is a big factor. They could be in a rhabdo we talked about. Sometimes these folks who have underlying psychiatric disorders actually have a metabolic problem that we just haven't diagnosed yet, such as hypothyroid, okay? All things I'd be concerned about is abuse or trauma. Why would anybody let their kid or family member sit on a couch for 3 weeks? So a quick rapid assessment. Remember, sick patients, you expose them, you look for life threats, you look for patches, for tattoos, right? For holes, things that kill people, all right? And what other things could be going on? So let's say instead of bradycardic, let's say her heart rate was 140 and her sats were 80%. What else could be going on with that girl that's been laying there still not moving for 3 weeks? A PE. Yeah, right. Cool. PE. Wait. We won't talk much about capacity. Capacity is a kind of a medical term that we use in the hospital. Can a patient really make an informed decision? Do they want to stay in the hospital or not stay in the hospital? It's not taught a lot in the paramedic programs, but in reality, what we're looking for is that patient understand the risk of them not accepting care. And I would say someone that has a heart rate of 40 and a blood pressure of 80, who's just not making much verbal sense, cannot do that. That was an easy one. That's a cool picture of a dog. How many dog people we got here? Raise your hand. How many cat people? But nobody votes on STEMIs. Great. I got 2 cat people, but they won't even vote on STEMIs. Thanks a lot. Yeah, you're very brave. All right, cat people, raise your hand one more time. There you go. Everybody look this way. Good. All right. All right. We talked about that. So 63-year-old male had a valve replacement in Huntsville, let's say. I'm not dogging Huntsville. Complaints of weakness, shortness of breath, a little bit nausea. Blood pressure is 90 by the engine crew. Respiration is about 16. Glucose is 200. Sat 91%. And they've already got him on their super fancy AED that has a rhythm strip monitor. And it shows a heart rate of 34, right? So that's their 12 lead. So STEMI or no STEMI? And then what 3 things can make you bradycardic? So who votes STEMI? Who votes no STEMI? All right, let's go back to cat and dog again, because I had a bunch of people raising their hand for the dogs. Yeah, so I would say the rate's too slow. I look injury patterns, 1, AVL, 5 and 6, 2, 3 in AVF, V1 through V4, AVR, and I go back over here to lead 2, and I'm looking for QRS complex. I would say not a STEMI, but way too slow. So I'm gonna look at this pretty quick. All right, so this is a bradycardic rhythm. 3 things make you bradycardic. You don't pick up on your primary exam: drugs, electrolytes, or ischemia. So not sure what's going on here, all right, with this EKG, but I know I need to start managing this patient. So the first thing we're going to do is we're going to sit them up. They get IV fluids, just like the hyperkalemic patient. What's the first drug this person should get after that? Narcan. Atropine, yeah. What's the dose of atropine? Yeah, so we learned years ago, 0.5 if you're alive, 1 if you're dead. In reality, my advice, give 1 milligram. If 1 milligram works, great, roll tide. Give your partner a high five, smoke a cigarette, take the patient to the hospital. If 1 milligram doesn't work, you're done. 2 is not going to work. So it's quick and it's easy. Hey, 1 milligram atropine, push that. All right, that works great. If it doesn't work, what's the next drug you can consider giving this patient? You can do some push dose epi. I'm fine with that. Push dose epi is very reasonable. Some places do epi infusions, super reasonable. What are some other drugs we can give? Dopamine is good. I like dopamine. Do y'all carry dopamine here? No, a lot of folks are just going to push dose epi. Dopamine's kind of gone by the wayside for the hospitals, but in reality, for symptomatic bradycardia, it's a great drug. So if you're using the dopamine, you spike it, you prime it, you hook it to the patient, you open it wide open. All right, then you start putting your pads on them. You start a second line. After about a minute, you look over. If the heart rate's increased, you crank it down to 10 mics per kilo per minute. If the heart rate hasn't increased, you look over, you crank it down to 10 mics per kilo per minute, and you start your epi. Okay. How much epi do you give them if you give an epi? Ah, gotcha. Yeah. Yeah, right. So how would you, what's the push dose? What would you do? Yeah. Yep. Yeah. Little squirts. I like that. You think like an ER doctor, little squirts. Yeah, that's right. Yes. Perfect. 5,200. Yeah. Yeah. So if you're doing push dose epi, make sure you know how to mix it up, right? So you're going to mix it up, take a cc of the 1 to 10,000, put it in 9 cc's of saline, okay? And then give, 1 to 2 mils every couple of minutes, just little squirts, as you say. I like that. The other option is you put a milligram of epi in a 250 bag of saline, you label it, and you titrate the effect like you would your dopamine. The goal is to increase that heart rate, increase the blood pressure. Either way is reasonable. There's one more drug I ought to give this patient before I go to pacing. What drug would that be? So you could do levo. Okay, more than one drug. Leave me alone. You could do some levo that increase the blood pressure. For the flight guys in here, would you give them neo? The blood pressure is 80. So they need neo. You don't have push dose epi, but you got neo sticks already made. You give them neo. Who says yes? Nobody's gonna raise their hand. Cat, dog again, right? I would not give them neo. What happens when you give somebody neo sometimes? They get reflex bradycardia. You give push dose neo to this person, And it's pretty cool because they go from a heart rate of 40 to a heart rate of 12. And you get to start doing chest compressions. And then your push dose epi is really just 1 to 10,000 because they're dead. So good. Yeah. All right. Sweet. The other drug I like to give these folks, I give them calcium. Why would I give them calcium? Could have been a calcium channel blocker. Yeah, very reasonable in our state. What's another reason I give them calcium? I got 3 reasons. What if it's hyperkalemia? It's slow. It's kind of wide. It's not as wide as that other one, but I'll say it's a little bit wide, complex QRS. Yeah. And the third reason I give calcium is calcium increases intracellular calcium in the heart. All these drugs we give, dopamine, epi, neo, they increase calcium inside the heart cells that makes the heart beat faster and get your blood pressure up. So if I give them a boatload of calcium, it's like a dirty vasopressor, increases the blood pressure. If they aren't hyperkalemic, if they didn't take a calcium channel blocker and I give them calcium, what harm did I do to them? Nothing. So risk to benefit, calcium's a good drug for these guys. Sweet. So we talked about this. My algorithm is fluids, atropine, calcium is quick and easy. Right? We talked about dopamine, know how to mix it, know how to give it. Push dose epi, you got to know how to do it. You don't want to be squirting people with 1 to 10,000, give them a couple of cc's. They go from a heart rate of 40 to a heart rate of 190. Okay. Not good. And then pacing is the last option. We'll play with some of that today with the sim stuff. So the way I manage bradycardia is my ABCs: atropine, calcium, dopamine, epi, pace. If I'm pacing somebody, I'm gonna probably sedate them and intubate them as well. People ask about blocks. Who cares? If they're symptomatic, we'll figure the blocks out later. If I go through all my drugs and I put that TCP on them and I'm pacing them, hey, guess what? They had a complete heart block. Right? Cool. All right. Inappropriate humor. And we're running a few minutes behind. So questions or comments within reason, and we'll take a break. Yes, sir. Oh, neosynephrine. Forgive me. The question is, what is neosynephrine? It's just a medicine that we use to increase blood pressure. It's like Levophed, but it works a little bit different. And some of the flight crews carry it because they can give it in push doses and not have to make an infusion. So it's super quick to use. And it's great for, so if you had a patient that was altered hypotensive and they weren't breathing, but they had a gag reflex and they had to take an airway, it's a good way to increase that blood pressure so we don't kill them when we put on positive pressure ventilation. So if they're tachycardic or something, or septic, but if they're bradycardic, you can't use it because it makes you get more bradycardic. Yes, sir. Other questions or comments? Yes, sir.
Yep. So I had a couple things. One was, would you suggest giving atropine to the first patient, the first case, the lady that was on the couch for 3 weeks?
So I would say no, because they're really hyperkalemic. If you gave them atropine, would it hurt them? Probably not. Okay. My thoughts on that one is you got to be able to recognize that that rhythm looks like that patient should be dead, not talking to you. So if you see a PEA looking rhythm like that and they're talking to you, your brain should say hyperkalemia. Okay. So and I treat any dysrhythmia with this Y complex QRS that's symptomatic with calcium, and I consider it hyperkalemia because it would bite you a lot.
So the other question or sidebar conversation was, we seem to have had an uptick in use in amitriptyline as a TCA. Yes. Can you get the same EKG look as hyperkalemia with TCA overdose?
Yeah, you to a degree, yes, you can. So you get with TCAs were used for depression prior to 1985, and then we realized that if you take too much of this antidepressant, it actually kills you. So we quit using it. It's come back into favor for people with chronic pain and older folks for some kind of mood support, I think. And what you see with too much of a TCA overdose is you see a prominent R wave in AVR, and then you get a Y complex QRS, and you treat that with bicarb instead. So again, that's a great tool you can use the EKG for, but I would argue you got to be able to read STEMI versus no STEMI. You got to recognize hyperkalemia first, and you just add on to those things like we talked about. Then you can add on that left axis, right axis deviation. But if you can't get the, I want to say basics, but it's really not basics. It's super advanced to do 12 leads, right? But you got to get those things down first because you're going to see more STEMIs in your career than you are TCA overdoses.
Yep, very good. I would say to go down that path, you probably need some on the scene clues, like an empty bottle of amitriptyline.
Yeah, right.
Right. Or
Yeah.
that on a medication list, or
Right.
some reason to think that way.
Yes, sir.
Thanks a lot. Great lecture, Dr. Ferguson. We're going to take a few minute break. Everybody online, if you haven't already done so, please fill out one of our attendance forms. The link is in the Q&A section. If you can't get to that Q&A section, please send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. For the attendance form, the password is Albertville, but all lowercase. The name of the town we're in today, Albertville. And we'll be back with Dr. Beach after just a few minute break.
All right. This is picking up on the audio, okay? Okay. Hey guys, my name is Logan Beach. I'm one of the emergency medicine residents at UAB. It's nice to meet you guys. I'm new to Alabama. There's a lot of Alabama-isms that I'm still gaining familiarity with to this day. I grew up in Portland, Oregon, and then I went to med school in Salt Lake City, hence the long hippie hair that my wife hates and detests. And yeah, I call it the flow. I told her that my idol is Nick Cage in Con Air, and she's not impressed by that whatsoever. I feel like that's the vibe. She does not agree. The thing I wanted to talk about today is GI bleeds, and to be truthful, this presentation is going to be a mixed picture between what happens in the hospital and what I imagine is going to be primarily you guys' responsibility pre-hospital. So why would I include some, I guess we could call them a little advanced information about what's happening in the hospital? To be truthful, some of the stuff I'm going to talk about today is not something that I'm going to do. It's not something that any ER doctor is going to do. It's something that gastroenterologists or even surgeons will do. And I'm not going to get off into the weeds about it. But I do think it's valuable to talk about some of these advanced maneuvers and procedures that are going to happen to them. Not because we might be doing them, but anytime we learn these, it's going to help us. I know that may seem kind of counterintuitive, but it's something that we in medical school will often talk about fairly advanced things, even if we're not going to be involved in those in our career. It kind of helps broaden your perspective of what's going to happen to them when they arrive in the hospital. But I'm also going to specifically try to flag information that I think is going to be important in the pre-hospital setting. And the other thing is I'm very sensitive to PowerPoints. One of the things I really appreciate about Dr. Ferguson is that most of his PowerPoints are pictures, funny memes. As somebody who sat through blithering thousands of hours of PowerPoints through medical school, they are dry, they are often boring, and so I also like to use the picture meme format. Is the clicker not going? I think we're frozen up. So I also like to use the kind of picture meme format. And the other thing I'm going to try to do is try to flag information that I think is important along the way. And I think it's important at the end of the presentation to just kind of like focus on the things. I know that when we leave, no one's going to take an hour of information and remember more than maybe 3 things, right? That's just what humans are able to do, unless we specifically note them down and then try to repeat them 5 minutes later, 2 hours later, a few days later. That's how we learn. We kind of have to repeat them. So I'm going to try to flag these, and at the end, I'm going to regroup and try to hit like what's the actual things I think we have to take away from this. Very good. Last thing I would say too is, and not to be a brown noser, but I'm just genuinely super impressed with what you guys are able to do. I'm new to EMS. It's not something I did before medical school, so I'm now rotating and I'm out with crews now, and I've just been genuinely. You guys all deserve like a legit pat on the back. You are operating in frequently austere environments, is what I would describe them as. You're operating on very little information, and you're making very critical decisions. And I feel like some people in the hospital don't often recognize that. I'm progressing. And for those of you online, we still have people online. For those of you online, when we get this up and running, some of the stuff that we're going to do is going to be a little bit participation based. So I'll do my best to narrate anything that we talked about in here because you obviously won't be able to hear it. I've also got some videos. They have audio that we won't be able to hear. So I'm just going to describe like what was going on in the video. There we go. Okay. So, we frozen? So I think there's a mixture. Most people in the room, medics, paramedics, we got some EMTs. Okay. Just so that I understand who I'm talking to, and if you need me to click this thing, let me know. Show of hands, like 3 years, 4 years, 5 years. If you're more than 10 years, just wiggle your hands. Okay. All right. That me? Okay. I think we're working. So this is where I'm going with the presentation. We're going to start off with a little bit of background information, and then I'm going to, maybe it'll work if I just stand over here and click the, yeah. All right, this is me. Okay. We're going to talk about the timing of the bleeds, how fast they are, fast versus slow. We're going to talk about what these patients look like on physical exam. We're going to talk about what hemodynamic stability means. I know this is probably something that's been drilled in multiple times. I think it bears repeating. This is something that interns, when they hit the hospital, which is now, is drilled in repeatedly over and over and over again. And I feel like it's worth just reiterating, even if you're super comfortable with this. We're going to talk a little bit about upper GI bleeds and then lower GI bleeds. My point is not to make this a big pathology lecture. And to be honest with you, when we teach these in medical school, we go real deep into the different etiologies of these and where they're coming from. But as an emergency medical provider in the ER or pre-hospital, I kind of think of the gastrointestinal system like a big pool noodle from mouth to butt, and it's bleeding somewhere. So to be frank, we can talk about their division. Is it upper? Is it lower? We're going to go over some of the basics and most of the common areas that they're going to bleed, but it's forgive me, a little bit irrelevant in the emergency situation if they're unstable. I prefer to think of it like a pool noodle with ketchup coming out somewhere. Does that kind of make sense what I'm saying? Okay. Talk a little bit about their management. And the whole point of this is to take mostly a 10,000-foot view. I'm going to skim the surface of a lot of stuff. We're going to hit some things fairly deep. And in the very end, one of the things I'm trying to flag for us is hemodynamic stability. So that's something I'm going to hammer hard in the end. We're going to repeat that one more time. The other thing I want to like really drill home is what's our management going to be and what do these patients look like on exam. So if you want to tune out other parts of this, totally fine. Try to hang on to those 3 things by the end, because I feel like that's the actual meat, what we're going to talk about. Most GI bleeds are upper GI bleeds. It's about 70-30. The dangerous, real dangerous GI bleeds are even more skewed to upper GI bleeds. The really brisk ones where patients are just going to vomit and die like the Blair Witch is usually an upper GI bleed. In terms of timing, I like to think of them as fast versus slow. I think in the emergency setting, I get very nervous about the top portion of this slide. In the lower, most people that show up to the hospital with a GI bleed are going to come down here. But the people on the top, some basic terminology or background information, you'll hear doctors and nurses saying acute, overt, brisk. These are the bleeds that everybody trains for. These are the ones that are voluminous, your variceal bleeds. I'm sure many of you have run into alcoholics who are throwing up all over the bathroom. They're jaundiced, they're yellow, they're obtunded, and they're just spewing just horror movie levels of blood all over the place. I was very shocked when the first time I saw that intern year. Kind of blew me away how well looking they can be and just how fast they spurted out of them. I feel like that's fairly uncommon for if you took all the GI bleeds, that's going to present less often than your slower, occult, chronic, indolent GI bleeds. It's a little bit more of a drippy situation. And a lot of these people will be older, some have cancer, some have hemorrhoids, some have frequently diverticulosis, diverticulitis. And it's one of those, hey, did you check a fecal occult blood test? And I'll get to that in a second. Did you do a rectal exam? Let's get basic labs. And no one's rushing to throw a scope down there and try to stop an emergent bleed. That's most GI bleeds. On exam, what do you guys, and this is one of our participation areas, and I'll try to repeat this out loud for everybody online, but what would you guys anticipate their vitals to be? Let's just say it's a brisk or an acute GI bleed. Yeah, low blood pressure, hypotensive, tachycardic. What about their SATs? This is, you do not have to guess what I'm thinking. It could be, I don't looking for a specific answer, so you're not going to be wrong. Yeah, most of them aren't going to be hypoxemic. Can they be? Certainly. Anybody who bleeds profusely can end up being hypoxemic. But you guys are right. Most of the time they're going to be tachycardic, and most of the time they're going to be hypotensive. In most people, and I'll hit this harder in just a second, which one of those vitals do you think is probably going to come first on average? Is it the hypotension or the tachycardia? It's the same in trauma patients. Almost always it's tachycardia first. Now, if you run into somebody who's throwing up gallons of blood, it's going to be both right when you find them, right? But if you run into someone who's tachycardic to 110, that can be very misleading, and we'll get into that in just a minute. They can look like they're stable. So yeah, you guys nailed it. Tachycardic. Their SATs can be anywhere from normal to hypoxemic. This patient I would classify as, given the context, if what they look like on physical exam matches what you're seeing in the vitals, I would call this patient acutely unstable. What on terms of physical exam, what might you expect from their skin? Pale? Anything else? Where would you see the paleness other than everywhere? Their eyelids, you pull those down. It's actually a really sensitive physical exam finding. It'll just look off to you. It's going to look not pink. It's going to look kind of whitish. The auricles of their ear is actually a very sensitive area to detect pallor. Their palms. And you can also just do the classic thing every first-year medical student does when they go up to do a physical exam. We're taught to do on our cardiovascular exam, you get 10 points marked off on your OSCE if you don't just press on their skin somewhere. You just push on it. If it's pink, they're probably, if they have a pink chest, their systolic blood pressure is probably at least 80. They're perfusing centrally. So pallor on the hands, pallor on the auricle of the ears. What would we maybe expect coming out of them? This is a little bit obvious in the setting of a GI bleed, but I guess could be. Yeah, so he said coffee grounds. Anything else? Well, so if that's a toilet bowl and we were describing it to a doctor when they got to the hospital, what might we call that? Lower GI? Why'd you say it was lower? Okay. This is kind of bright, but yeah, it could also, lower GI bleeds can be dark. I'll show you another picture here in just a second of like a really dark one. So the medical term that we would use for this is hematochezia. You guys heard that one before? That's bright red blood per rectum. What he was talking about just a second ago, and I'm sure all of you have seen this, you've all seen all of this, is melena. Some people call it melena. Those people are wrong and weird. But this is melena. It smells foul. All these GI bleeds smell foul. I don't think I've ever smelled anything worse than a GI bleed. What else might we see? We talked about coffee ground emesis. Has everyone gotten a chance to see that? Kind of looks like this. So kind of looks like mushed up beans and water or coffee grounds. You know, that's why we call it coffee ground emesis. It looks exactly like coffee grounds. And then you can also just see bright red vomit, which we'd call hematemesis. So we've got hematemesis, coffee ground emesis, which is fancy medical speak for red blood out of your mouth, coffee blood out of your mouth. And then we've also got bright red blood per rectum, which is hematochezia. And then we've got dark blood per rectum, melena. Now I'm going to hit this again in just a second, but what's often taught in medical school is that if it's bright red, like he was hitting on, if it's bright red per rectum, that's going to be a lower GI bleed. And sometimes they'll say, we'll get into that in just a second, but I'm gonna kind of take a little bit of a dump on that, so to speak, pun intended. And then, have you guys ever seen this before? Okay. This is like an acute variceal bleed. This is from one of the emergency medicine journals in Europe, and they can be very violent and shockingly so. So I would call this frank hematemesis. Now, one of the things I wanted to hit real quick is on our differential diagnosis. Well, we'll hang on for a second. So if we were to go over a textbook definition of hemodynamic stability, it would read something like stable condition of the cardiovascular system where the blood pressure, the heart rate, the cardiac output are all within normal ranges, and we are ensuring adequate perfusion and tissue of organs. The most important part of this sentence right here is ensuring adequate perfusion, not necessarily that the heart rate and the blood pressure were within normal limits, because they can be outside of normal limits and you can still be perfusing the tissues. But this is like what a physiologist would say about hemodynamic stability. This is not what an ER doctor would say about hemodynamic stability, or what I would expect a medic to say. How would you guys just describe it? And I promise you there's not a wrong answer to this. That is a great way of explaining it. I feel like if somebody is confused and drooling on themselves, and then this happens all the time, the internal turn, they'll say they're hemodynamically stable. Maybe not, right? If somebody's blood pressure is low and they're already starting to get confused, I feel like the brain is the most sensitive organ in detecting hemodynamic instability. The brain is kind of a wuss. It demands oxygen. And so it's one of the first signs you're going to see when they're acutely dropping their blood pressure on physical exam anyway. So let's say you're dispatched to a house by the mother of a 28-year-old male. She's unable to provide much information to dispatch other than he is not acting like himself and he's lying on the floor in the living room. So this is a case that happened a few months ago that came into pod 2. There's this famous all the residents joke because pod 2 is supposed to be our lower acuity pod in the ER. It's where the interns go to train and like spread their wings and fly. And everyone kind of joked with me that, you know, we treat it that way, but in reality, probably the sickest patient you're going to see in residency is going to happen there. And it came true for me. This was a few months ago. And I don't know if anybody from Trustful Fire is online right now, but they were the one that brought him in. And this young man was yellow. He had a hugely distended abdomen. He reeked of alcohol. So that's the context. So with that in mind, what else do you guys want to know? And what are we going to do next? Anybody can answer this. We'll just step through this case together. And again, promise you no incorrect answers. What other information would you guys want to know? He has no medical history that we know about other than alcohol use disorder. He's 28. Doesn't take any medications other than fentanyl. Probably his mom said about a fifth daily on top of multiple beers. What else? Yeah, let's talk about it. Let's talk about physical exam. First things you guys are going to look for are the things that vitals, right? So let's say that these are his vitals. That's his heart rate, that's his blood pressure, his O2 set, his temp, his respiratory rate. And his GCS in front of you goes from 14 to 9. What are we starting to get worried about? Yeah, in terms of his vitals, what are we getting worried about? Did you say might take an airway? Yeah. We'd worry about it, right? Yes, this is going exactly where I was hoping we would go. Let's have a conversation about hemodynamic stability. Show of hands, who suspects that this person is hemodynamically stable? Good. I feel like because of the way I'm, okay, yeah, why would you feel like he's hemodynamically stable? I love that answer. That is exactly where I was going with this. That's exactly where I was going. So one real big mistake that pre-hospital providers can make, nurses make, ER doctors make, general surgeons make, everybody makes this mistake, is that we will see these numbers and then we will say blood pressure is 120 over 80. They are hemodynamically stable. Almost everyone does this. I've caught myself doing this, but remember, yes, in the definition, what physiologists would describe as hemodynamic stability, they're going to include vital signs being within normal limits. But what if I gave you the context that you guys go into the bathroom? Do you remember that picture from a few seconds ago and it was just blood everywhere? You go into the bathroom and you find that. And then you go into his mom's bedroom, and this is really what happened. His mom's bedroom, where his mom found him, is blood soaking the mattress everywhere. And then you guys encounter him on the living room floor, and those are his vitals. He's compensating, but is he hemodynamically stable? I would argue no. I would argue he's acutely hemodynamically unstable, and he is about to code, which is actually what happened. He started coding within probably 10 minutes of getting into the hospital. But his vitals when he got there looked exactly like that. So no one's going to look at that and be scared. As a matter of fact, when they got him into the ER on the stretcher, we were all just kind of sitting there looking at the monitor on the back of the stretcher. And I looked at this and I'm telling you, I thought, oh, this guy's fine. And walked back to my computer. He coded, I think, 8 minutes later. So this is a mistake I made. This is not me trying to say, hey, you guys need to do better at looking at your vital signs. I looked at those and I was like, oh, his blood pressure is 120 over 80. This guy's fine. And I took the report from EMS. I heard them say, hey, there was blood everywhere in the bathroom. There was blood all over his mom's mattress. And it just kind of went in one ear and right out the other. And that is history is a big clue to this. And a man that's confused, I did the exact same thing that he said. I forgot your name. Wesley. I did the same thing that Wesley did. I was like, oh, he could just be drunk. That could be why he's confused. His ethanol level actually wasn't very high. He was also withdrawing. I don't remember. Yeah. And they hadn't bolused, which I was kind of happy about. What else would we expect on physical exam? Just generally in this patient, he was jaundiced. He looked like a banana, like a highlighter yellow head to toe. He had all these angiomata all over him. and he also had red palms. He was kind of the medical textbook definition of a cirrhotic patient. He had them on his face. He had a big yellow distended abdomen, and that's what was in the bathroom. So we just talked about, is that guy hemodynamically stable? And I'd say no. I won't spend a ton of time on this slide. All I was trying to say by this is that in the different classes of shock, this is how it's taught in trauma. I'm sure some of you guys have seen something that looks like this before. But all I wanted you to see is watch the heart rate. So in class 1 shock, our heart rate is probably going to be normal. Our systolic blood pressure is probably going to be normal. But in class 2 shock, you're going to start seeing a heart rate change before you start seeing a blood pressure change. And as you progress through the shock classes, your heart rate, your blood pressure is going to lag. And most there's different texts disagree on what these classes are and at what stage you reach them, but all of them agree that your blood pressure is going to lag behind your heart rate. That's really the only point I wanted to make here. So if you see somebody who's altered, confused, they're bleeding everywhere, and their heart rate's 110, and their blood pressure is normal, that isn't always going to be a reassuring finding. So hemodynamic stability is a fluid, functional exam that you're going to have to reassess over and over again. And I feel like I'm kicking a horse to death, but this is really the only thing I wanted to actually drive home in this presentation, is that in the pre-hospital setting, most GI bleeds are going to be chronic indolent little drippers. Some of them are going to be voluminous, nasty variceal vomiters. And those are the ones, even if they have normal blood pressure, that I would be very careful with their hemodynamic status. I don't know if I'm going to be able to get this video to play. Hopefully I can. Oh, it's because I'm not signed in on YouTube here. How do I get back to this presentation? Okay. There we go. So on that video, and if you guys are around afterwards, I'll show you, it's profuse vomiting. Has anybody gotten to see somebody bleeding varices, spitting up everywhere? I feel like probably most of you have at this point. It's impressively violent. So anatomy, I won't focus too long on this. For those of you online, you can't see my hand right now, but if you were to just draw a line right under the stomach, and I'll just go 2 slides forward real quick. So this artificial line, this blue line, is where there's this ligament that holds the duodenum to the body wall. It's called the ligament of Treitz. And for some reason, anatomists just decided that, surgeons and gastroenterologists just decided that anything above this line is going to be an upper GI bleed, and anything below that line is going to be a lower GI bleed. I don't think that distinction is very important, to be honest with you. But just to briefly touch on some things that you guys can keep in your minds, differential-wise, for what's going on during a GI bleed. We can have ulcers in our stomach, and we can have ulcers in the duodenum. I feel like peptic ulcer disease is one of the 2 most high-yield things to keep in your mind if you see a sick upper GI bleeder. The other one that I would draw to your attention is varices. So you can have varices in your esophagus. You can have varices up in the fundus of the stomach. There's different ways that you can get them. I feel like most of the time you guys are going to encounter this in alcoholics or in non-alcoholics who have cirrhosis. So I feel like the common denominator here is going to be patients who have a stiff, fibrotic liver. And the reason for that is that most of the venous blood flow from your bowels goes into your liver. It should pass through your liver and go up into the heart. If you have a stiff, fibrotic, resistant liver, you have backflow, and that backflow goes up to the stomach. And it also goes up to the esophagus. And they get these big, ugly, dilated veins because it's backflowing. And eventually, one of those suckers is going to pop, and it's going to spurt blood everywhere, and it is violent and fast. So in terms of upper GI bleeds, a lot of these other ones we could talk about, but I do feel like ulcers in the stomach, ulcers in the duodenum, and then varices are really important to keep on the EMS differential for why are they throwing up so much. Again, is that going to change a ton of pre-hospital management? Probably not, but I do feel like it deepens our understanding. In terms of lower GI bleeds, a lot of them, the majority of them in older people are from diverticula. You get these little outpouchings of the colon, and those are likely to bleed. They're usually not going to be these rapid hemodynamically unstable bleeds, but they certainly can be in like a little old lady. Hemorrhoids are very common, lower GI bleeders. Cancer. So if you have this guy who's just got this chronic dark stool, he's had them progressively for months. He's 65 years old. He's got iron deficiency anemia, which is new. Every medical student that hears that in the country is ready to answer on our board exams, cancer, 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 every single time. It's just the first thing that pops up into our heads. But again, most of these are going to be the slow drippers. I won't blather on too much about the rest of these. You can have these weird structural abnormalities in the bowel, angiodysplasias. For you guys, we can get patients like pediatric patients, if they're bleeding commonly, if they're like little kids, like 2 years old, they can have these little Meckel's diverticula, which are these little outpouchings, and those like to bleed. We also have intussusception. So little kids like 1 year old, if they were fine and they're writhing in pain, and then they're fine, writhing in pain, and then they're pooping something that kind of looks like grape jelly, it raises my concern for an intussusception. It's where the bowel kind of telescopes in on itself. Those, if a little kid's having a bleed, and it's also, he's had this rolling abdominal pain on exam that's coming and going and coming and going, that kind of perks my interest in that. And then trauma patients and GI bleed patients, or anyone who's hypovolemic, their small bowel and their colon are very sensitive to low blood flow states. And so they can get very ischemic very quickly. So if you got somebody who's shot or stabbed in the abdomen and they're bleeding out, the most likely area that's going to be damaged is going to be on the left side of the colon, right there, at the splenic flexure. They can also infarct any of their bowels, the superior mesenteric artery, the inferior mesenteric artery. Bowels are very sensitive to this, and their lactate's going to start rising. Like I said, going into the deep pathology of all this, I don't feel like is frankly important or helpful in the pre-hospital setting, because I like to think of this whole thing like a big pool noodle with blood coming somewhere. Am I in the ER as a doctor going to be able to discover which one of these things it was? Maybe, probably not. It's usually going to be done with endoscopy. So what I'm going to do is make sure that they're stable, get them to medicine, because gastroenterology doesn't typically admit people. They're a consulting service, and then they come in and they will scope later. And they love to play this game of, well, they're too unstable, we can't scope them now, or they're too stable, they don't need a scope, right? But in the ER, we're also not going to find out which one of these things it was either. We're just going to try to make sure that they were stable and then get them admitted. I don't want to spend a ton of time on this, but I just wanted to make an important point. When the basics of GI bleeds are taught, we frequently say, all right, if it's bright red blood coming from the mouth, if it's really anything coming from the mouth, you should think it's an upper GI bleed. Technically, some lower GI bleeds can cause, if you have a lower GI bleed and you also have, for example, a small bowel obstruction or reason to have backflow, you could have refluxing coming up from your bowel out of your mouth. That's a weird scenario, and I wouldn't try to think of it or classify it that way. So if someone's got blood coming out of their mouth, if it's bright red blood or if it's coffee ground blood, it's probably an upper GI bleed. I would say almost certainly it is. One important thing to keep in your differential, if they've got blood coming out of their mouth, is not a GI bleed, but bleeding from somewhere else. Where might you guys think that they could be bleeding from? It's coming out of their mouth. Yes, so what if it's not a GI bleed? It could be their lungs, and we call that hemoptysis. Usually it's going to be bright red, just like varices could be bright red, but frequently it's speckled with air. So it's way that they could have bright red blood coming out of their mouth is just epistaxis, a nosebleed. I would say anything that's brown, you already know it wasn't hemoptysis, because what's turning it brown is traveling through the bowel somewhere. It's the acid that's turning it brown. So if it's bright red blood coming from the rectum, every medical student in their first year medical school is taught, oh, that's a lower GI bleed, which is something that he was keying in on. What I would say is that that's a common pattern if it's a slow GI bleed. So the longer blood has to move through the pool noodle, the more likely it is to turn brown. So if you had dark black melena coming out of your rectum, it's likely to be an upper GI bleed. Because usually if it's a lower GI bleed, it wouldn't have enough time to turn black by the time it came out. Is that 100% always going to be the case? No. And there's so much overlap on this Venn diagram. The only really important part I want you guys to take away from this is that frequently when this gets taught, we get taught, oh, if it's bright red blood out of the butt, it was a lower GI bleed. But if they're acutely unstable and they have a really fast upper GI bleed, like they had a perforated duodenal ulcer, they will have bright red blood spewing out of their butt. And it is not coming from their lower abdomen. Does that make sense? It doesn't have time. It's moving so fast through the bowels, it doesn't really have time to turn brown. The rest of this, I feel like, is a little bit unimportant and off into the weeds. So imaging studies, when they get into the hospital, EGD, EGD, EGD. If they're acutely unstable, they're going to get an endoscopy. If they're stable, they're going to get an endoscopy. It just changes how fast they're going to get one. They're going to get a scope in the mouth. They can also get a scope from below. They can get a colonoscopy. But for most acutely unstable patients, the first thing they're going to do is an endoscopy. So if they're hemodynamically unstable, we'll do the EGD. There's one more thing we can do that happens a lot in the ER when gastroenterology is not wanting to come see them. We'll get a CT angio. And what that's going to do is we put dye in the blood vessels in the bowel, and we can actually watch it slowly extravasate during the CT. And you can pick up bleeds even if they're kind of slow. If they're hemodynamically stable, same thing, EGD. And if you don't see anything on the EGD, you can do a colonoscopy or, again, a CT angio. And if the workup is still, if we still can't find it, it could be because it's in the middle of the abdomen somewhere. And we usually talk about upper versus lower GI bleeds. There are bleeds in the middle too. And they have to use these fancy scopes, and it's called push enteroscopy. And they try to make all this sound fancy, to be honest with you. It's the same thing as the endoscopy or the colonoscopy. They're just pushing it a little bit further, and it's slightly smaller. But of course, because it's medicine, we have to call it a whole bunch of fancy stuff. It's the same thing. So if you have suspicion that a patient has an upper GI bleed and they have hematochezia and they're hemodynamically unstable, we're doing the EGD first. Does that make sense to everybody? Okay. We're going to skip that one. Your CT angios, when they get into the hospital, we can actually see them bleeding on the scan. And it can pick up fairly slow bleeds, even if it's only like a half a mil a minute. We're going to skip this. On lab work, we're going to get a CBC. We're going to get coags. We're going to get a hemoglobin hematocrit. We're going to look at their platelets. The thing I wanted to draw your attention to is then in the hospital, if they have an elevated BUN to creatinine ratio, that raises our concern about upper GI bleeds. And I'll explain why in just a second. We're going to check their lactate. We're going to check an albumin, coags. We're going to get a type-in screen. All of these things are fairly basic. So the reason that an elevated BUN to creatinine ratio is hinting at an upper GI bleed for us is because of how urea or how hemoglobin is broken down. So if you're bleeding somewhere, let's say you had a peptic ulcer disease and your hemoglobin molecules are breaking, your red blood cells are breaking apart and they're spilling hemoglobin. The hemoglobin is just an iron molecule, and then globin, which is a protein. And when globin gets broken down, those little amino acids get processed in the liver and they turn into urea. And then urea becomes, or on our lab, it becomes our blood urea nitrogen. That's what the BUN is. So when somebody who's got a GI bleed and they're dumping a bunch of blood into their stomach and the blood's popping open and then the globin molecules are getting ripped apart and processed in the liver, their urea goes up. And so therefore their BUN goes up. So the first thing we're looking for on the labs, if it's a stable bleeder, I mean, by history, if somebody's vomiting a ton of blood and they're hemodynamically unstable, that liver patient we were talking about earlier, do I care to wait for their BUN? No. But for most of the GI bleed patients that are coming in as chronic little drippers, one of the things that can hint at us that it's an upper GI bleed is just their ratio on their lab values. I don't want to spend a ton of time on this, but I know that you guys probably aren't frequently doing rectal exams on these patients. I'm not saying you need to. One thing on your exam, though, a lot of these patients you're picking up in bed. Some of them are elderly. Some of them are wearing diapers. Quick little, just pull the Depends back, take a look. Is it red? Is it black? Is it dark? Is it smelly? Foul? You don't necessarily have to be doing a rectal exam. In the hospital, there's still a lot of debate right now about whether or not you need to do fecal occult blood testing. Have you guys seen doctors doing that on like a little card? They stick their finger up there and then they wipe it on a card and then they put antibodies on it. There's lots of debate about this. I feel like the majority of people are now realizing that in the hospital, there's not a ton of reason to actually do that. Clinics will do these, family medicine doctors will do them to look for like slow screening of blood instead of doing a colonoscopy. That's one of the early catches of cancer sometimes in the outpatient setting, get like one every year, every 2 years. In the hospital, there's not a ton of reason to do that test anymore. So what I care about is, do they have bleeding coming out of their butt that I can see? That's bad. If I can stick my finger up there and then I find it on my glove, that's good enough for me. I don't need to test it because that test is prone to lots of errors, lots of false positives with that test. Your diet can make that test positive. I don't really care. So to me, it's if they have enough that I can catch on my glove, that's good enough. That's good enough for me to talk to the hospitalist or the gastroenterologist about it. I feel like if you're picking someone up and taking them in on an ambulance, take a look back there. You don't need to be doing a rectal exam, obviously. Okay, this is kind of the meat and potatoes of what I wanted to get to, and then we're going to stop here. So in hospital management of GI bleeds, what's going to show up in red text is going to be similar between in-hospital and pre-hospital management. So 2 large bore IVs, IV fluids, I kind of made that text smaller on purpose, and I'll get to that in just a second. Blood, 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 that is the treatment for a GI bleed. Probably pretty intuitive. If they're losing it, they're going to get it. Same thing as a trauma patient. I said if their hemoglobin is less than 7, and then I said in parentheses or. Now, do I have to wait? If somebody's hemoglobin is 7 and it's one of those acutely hemodynamically unstable patients that we were talking about earlier, and I check a lab and we haven't gotten blood yet because I'm waiting on a quick pack to come down, and the nurse says, hey, his CBC was 9. Do you still want to transfuse? And he's one of the patients we were talking about earlier, throwing up everywhere. Blood pressure is 90/40, heart rate's 150. He's altered. Do I want to transfuse that guy? What if his hemoglobin's 9? I thought we don't transfuse anybody whose hemoglobin's less than 7. Or sorry, greater than 7. Correct. We treat that patient. We won't treat that lab value. And the reason is that CBC can lag behind them. That CBC may look normal, but what's really happening is we've just taken the Kool-Aid in its concentration, spilled some of the Kool-Aid out, and then we reach in and we sample some of that Kool-Aid, and we're like, oh, this is roughly the same proportion of Kool-Aid package flavor to water. And so we can reassure ourselves that that hemoglobin is 9 or the hematocrit is 23 or 25. When in reality, they've started to greatly compact and decompress their blood volume overall. If that didn't make sense, it doesn't really matter. If they're unstable, we transfuse. If they're unstable, give them blood. They're losing blood, give blood. That kind of makes sense? Other medications we give IV proton pump. Especially if they have peptic ulcer disease, the people that have ulcers in their stomach or ulcers in their duodenum. If they have cirrhosis, if they're one of those variceal bleeders, we'll give them ceftriaxone. No one really knows why this is saving lives. We just know that it is. Some people guess that a lot of cirrhotics also have spontaneous bacterial peritonitis. Maybe it's helping with that. I don't really know. I don't really care. I just know that it helps, so I'm going to give it. Sometimes we'll give people DDAVP or vasopressin. There's lots of complicated mechanisms that people propose for how this works. I don't really know how it works. Somehow it's helping relieve portal hypertension. And then for really, really unstable people, we'll do massive transfusion. Anybody seen massive transfusion happening in the hospital? It's that when we get that Belmont in here, it kind of looks like this little machine. Nurses will come in, they'll plug in blood right here, and we can transfuse almost a liter a minute. That's technically how fast we can basically replace somebody's blood volume in approximately 5 to 7 minutes, their entire blood volume. I've seen happen a couple times. It's really fast. It's pretty nifty. But that massive transfusion, when we're giving it, we're giving a roughly equal proportion of red blood cells and platelets and fresh frozen plasma. We kind of do it in this 1-to-1-to-1 ratio. In the pre-hospital setting, IV access, see how it's kind of the same in both cases? Crystalloid, I made crystalloid intentionally small over here, and I made it bigger over here. I think that in the pre-hospital setting, if you have an acutely unstable patient, like the one we were talking about earlier, very reasonable to give IV fluids, right? Most EMS crews are not running around with blood. I know that some are, and if they have them, certainly we should be giving it. Flight crews have them. But if what you have access to is IV fluids, that's going to help. Now, the reason we don't give them as much in the hospital anymore is because we we have access to blood, and we're going to dilute them, and we're going to be fighting ourselves, and they're going to get a little bit more coagulopathic. They're going to enter what we call the triangle of death. They get a little more acidotic, they get more coagulopathic, and they get a little colder. And IV fluids are going to make all of that worse. But in the pre-hospital setting, when you guys are ripping down the highway with a patient whose sats are dropping and their mentation is failing and their pressure is atrocious, fluids, it's going to help their perfusion. Yes, is it going to dilute out their red blood cells? Sure. Maybe somebody will kind of like look snidely when you get to the hospital, whatever. But I would give fluids because it's what we've got. We got to treat with what we got. We got to work with what we got. Does that kind of make sense? In the hospital, we avoid this and we go to blood first, but that's because we have it. Blood, if you have it, and then dry fast. If they're a really acute upper GI bleed, you got to move. Yeah. You are a plant. I knew somebody was going to ask that, and I'll get to that in just a second. We probably it's controversial, but there was a big trial done in 2020, and the answer is, from the trial, probably no. So for OB emergencies, postpartum hemorrhage, and for traumas, TXA. We'll get to that in just a second. Coming to the end of this, ignore the fact that he's wearing a football helmet for just a second. There's something that we can do in the hospital for these patients that are really, really unstable. We can stick something down them called a Blakemore. It seems kind of fancy. It is not. It is, in fact, basically just a large balloon. There's a balloon that goes in the esophagus. There's a balloon that goes in the stomach. And what we're trying to do is tamponade that bleed. Do you guys know what I mean by tamponade? Just pressure. Just putting pressure on it with a balloon. And the reason he's wearing a helmet right now is because I'm going to skip the video. I had this video of one of these ER doctors setting up a Blakemore tube so that you guys could see it. We're kind of at the end of our time, so I don't want to keep you over. But what we do is once that tube goes in and it's inflated in the stomach, if I were to pull on that tube, is it going to come out right now? No, it's just going to get stuck on the gastric opening right here. And so we actually intentionally put pressure on it. So we'll tie something off to the tip of this Blakemore tube. It's usually an IV bag, and we'll hang that IV bag over a pole, and it kind of just sits and like pulls tension on them. It's actually a little uncomfortable to look at, and I'm sure it's uncomfortable for the patient too. Usually they're intubated at this point because they had a bleed that was so unstable that we took their airway. But we put pressure on it so that that balloon can tamponade the top of the stomach, because where are varices in the stomach? Usually right there. Where are varices in the esophagus? Usually lower. And so you can inflate both this gastric balloon and the esophageal balloon to try to stop those bleeds. And then we kind of put pressure on it. The reason this guy is wearing a helmet is because it used to be taught back in the old days that you would hang a football helmet over the top of it to like add some pressure. I don't think anybody's actually ever done that clinically. So we'll skip this video. That's just her showing you how you put this in. So I will not get into the details of this trial because it's 11 a.m. But to answer your question about TXA, the HALT-IT trial, I think it was done in 2020. I don't like slides that have lots of text on them, so I kind of hit it with boxes so we don't. I get super confused and I try to read the slide and I can't listen at the same time. So the question was, does tranexamic acid reduce 5-day death due to bleeding in adult patients with acute GI hemorrhage? What they did is it was a big international trial. It was a multi-center, 164 hospitals over 15 countries. The TXA group got 1 gram loading dose of TXA, and then they also got a 24-hour dose. And then the comparison group was a placebo group. We don't need to go over the inclusion. We don't need to go over that. The conclusion of this trial was that it was performed very well. There wasn't a ton of structural errors to the trial. No benefit of giving TXA on 5 in terms of 5-day mortality, and there was a small signal of harm with increased DVTs and seizures when you gave TXA. So is this definitive? Does this mean that nowhere in medicine are people going to give TXA? No, actually, it still happens all the time. This was a fairly new trial. People have not really adapted to this yet, and I'm not even saying this is 100% the God-given truth. It's just one of the kind of like the newer things that came out in the past like 2 or 3 years. So yes, TXA still gets given for GI bleeds. It is still given for GI bleeds sometimes at UAB and in various other hospitals. But some of the thinking now in emergency medicine is to focus on OB emergencies and trauma as the mainstays of treatment for TXA, and then there's a couple others. So big takeaways, the things that I think are important to remember from this. Most bleeds are slow, some are dangerously fast. And there's not a ton an ER doctor can do from them. There's not a ton that you can do pre-hospital other than get them there quickly and tell somebody, hey, I know their blood pressure looks normal. They are not okay. That's probably the biggest, most helpful thing that anybody could do. Hemodynamic stability, I feel like I've sufficiently murdered that horse. We talked about on exam, you can have hematemesis, coffee ground emesis, you can have melena, hematochezia, and pallor. Remember that the bleeding, and whether it was bright red or coffee, above or below, it's not as important as the fact that it was happening. 2 large bore IVs, that's probably the single most important thing that any of us can do before they get to the hospital, because everything about these patients is, especially if they're unstable, access and blood. And then we try to support the perfusion with what we have. Blood, if you've got it, IV fluids if you don't. Most people don't bleed to death from a GI bleed. The majority of them actually die from other causes unrelated to the GI bleed. In modern medicine, we're pretty good at getting people transfused, even if they're unstable. Most people don't actually die from the bleeding itself. They die from complications related to their hospital stay. All bleeding eventually stops, and the majority of non-variceal bleeds will stop spontaneously with the patient still alive. Early resuscitation and supportive care are key to reducing morbidity and mortality. That's probably readily obvious to you guys. And in a good, better, best scenario, it's best if you can generate a differential for where the bleed is coming from, upper versus lower. That would be best case scenario. It's good enough to just recognize that the GI system is just a big pool noodle that is bleeding somewhere. So it's great if you could come in with confidence and be like, this is peptic ulcer disease, and here's how I arrived there in my mind. That's awesome. It's good enough to just say, hey, doc, they had coffee ground emesis. I feel like they're hemodynamically unstable, and here's why. That would be excellent. And that's all I had. I won't play this video because we're kind of out of time. If you guys have any questions, happy to answer those, and I appreciate all your guys' help.
Yeah, questions online, Chief. Great talk, fantastic. I would clarify that we talked about rectal exams. There's no reason to do rectal exams or hemocults in the field.
Praise God. Yeah.
Yeah. So the only really 2 times you want to look at that orifice is if you think a baby's coming, you look down there, or there's trauma, you look down there. On that note, there are some families that still give rectal Valium for seizures. We should not be doing rectal Valium. We should not be doing rectal glucose for people either. Just to clarify, in case there's a question out there. And yes, the reason I'm saying that is because it's been done. So, with the TXA, remember that halted trial was a 1 gram dose. So the places that I work, I'm not a big fan of the halted trial, so I'm using TXA. If I have someone that has bright red blood out of any hole and they're unstable, they get 2 grams of TXA, limited risk, potential benefit. If you have blood products, they get blood first, because like you said, blood is the volume resuscitation for trauma. You lose blood, we give blood back. And the other thing I want to mention, I think somebody had a question earlier about airway management. If you have someone with an upper GI bleed and you are advanced practice, you are able to take that airway, because the risk of aspiration is pretty great. Remember, they're probably going to be unstable, hypotensive, so you're aggressively treating their hypotension with volume. Talk. Thank you, sir. That's all I got.
Yep. Hey, y'all covered all the questions we had coming in, which were mostly centered around TXA. Did have a comment about please be careful with overly aggressive crystalloid fluid. And I would agree to be careful with over aggressive fluid resuscitation, like pressure infusers and
Yeah. I mean,
all
a
that
couple
stuff.
liters is reasonable. We're going to do that for most anybody anyway.
Yeah.
And obviously, if you have blood products, plasma, that's what you can go with first. But
Yeah.
I mean, like you said, you can only treat with what you have. The other thing I wanted to say is that helmet that you saw, we have used that helmet, but most of them have a big 8 on it for some reason. I'm not sure why. That was kind of funny. Maybe not. Okay. It was a Georgia Bulldog.
One thing I wanted to clarify about the TXA, I hope I made this clear, is that is a hotly debated topic. And so if you talk to a doctor and they're like, no, I never give TXA, you're going to talk to another one that will. And so my only point with bringing up this trial is that if you sense some back and forth with this sometimes, it's because there is back and forth with this. And you're not wrong for questioning this. I don't really know what my attending is going to want to do with this, and I've seen both done. So if you feel like you don't know what's going on, I don't know what's going on either. But the reason people don't know what's going on is because of big trials like that throw everything into question.
Yeah, so we did have one question, actually just came through, asking any increased benefit to using a colloid, like a head of starch product instead of large volume crystalloid fluids if blood's not available, and there's going to be a prolonged transport.
Yeah, I would say probably not. I mean, you can use that and it shifts the fluids for a few minutes, but then you're kind of playing catch up. Not a lot of places carry it. So I think with the fact that in our state, non-critical care can carry blood products, if you have the funding and the desire to be aggressive, why get that, move forward and get you some blood products and just do that. It would not be my advice.
Yeah, it's been my experience that people start talking about colloids usually have come out of a military context. I know it used to be really popular in military medicine, battlefield medicine, to use colloids. There's some old studies on that I've read a long time ago, but my understanding is that from an outcome perspective, there's no real difference between crystalloids and colloids, and that's why it hadn't been pushed. Plus, there's a shelf life and cause tissue and so on and so forth.
You're better off just getting blood products because we can do that now.
Yep, but great question. We really appreciate the question, and great lecture, Dr. Beach. We appreciate you. Everybody, please realize that we're taking July off. We're not going to have an event in July. Is that right, Doc?
That's correct. Next one will be at Brim's the second Wednesday of August. The third Wednesday will be at Dega for a makeup, and fourth Wednesday we're going to be in Prattville. So we're back hot and heavy, plus the cadaver lab.
Yep. So we're going to have a really busy August, but we're not going to have any events during the month of July. Once again, if you haven't already done so, please fill out an attendance form today. You'll have a certificate automatically emailed to you. You can get the link if you're online. If you're here in the classroom with us, I'll put the QR code up. I'll run the ad here for a good while after we go offline, just so you can get that code. If all that fails for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the form. The password for the attendance form is Albertville, all lowercase. And that'll do it for today. Thanks so much for joining us.